Hello, good afternoon, everyone. Thank you very much, Peter. I think there's some echo here. I hope that this will go away. And I wish I could be with you this afternoon. I was advised against driving this morning. I hope that you and your families and the staff are coping well with the pandemic and with the weather storm. I'm going to talk today about a very hot topic that has not unraveled yet in terms of evidence-based studies, but I'll do my best to gather all the available evidence to reach some conclusions regarding the impact of COVID-19 on the course of neuromuscular disorders and regarding the associations between COVID-19 and the some of the reported neuromuscular diseases, such as GBS. Also, we'll talk about complications resulting from prolonged hospitalization, and we'll talk about the significance of vaccination against COVID-19 and about the long-term neuromuscular complications of the virus. The last time I looked at the statistics, which are very scary, was yesterday. Seems that COVID-19 has so far taken the lives of close to 6 million people worldwide and close to 1 million Americans. If you translate that to per 100,000, it comes up to about 340 people per 100,000 died from COVID-19, which is about 8 times or 7 times more than the mortality from all the neurological disorders in 2021, which was about 47 per 100,000. So this is a real drama, it's a real tragedy that is unfolding in terms of its complications and long-term impact. But I hope that it is the curve has started going down. And I hope that what we have seen over the last few weeks would be the last serious part of the pandemic. Studies have shown that neurological complications and manifestations are common in patients with COVID-19. 82% of COVID-19 patients had some kind of neurological manifestations, including headaches and loss of taste and smell, encephalopathy, coma, stroke, dysautonomia, and sensory abnormalities. Remember, 1% is a lot, given the huge impact of the COVID-19 on the population. So even 1%, even 1 per thousand is considered a very high number. Now, the neuromuscular manifestations or complications or associations are there. A lot has been said about them, but there are some very hot topics and hot questions that people want to hear about. We always get calls from patients, from physicians. Is GBS more common with COVID-19? Should people get vaccinated if they had a previous GBS? So we'll try to address some of these questions. Since the pandemic started here on March of 2020, many case reports came out about GBS after COVID-19. When I reviewed that a few weeks ago, about 100 cases were reported of GBS after COVID-19 within 4 weeks. The studies have revealed very conflicting data. Some of them suggested some increase, and some of them did not show any change. But altogether, the GBS cases really were not very much different than the regular GBS without COVID-19, except the increased pulmonary morbidity, and that's understandable, basically because of the impact of COVID-19 on the lungs. Otherwise, the COVID-19 associated GBS is not very much different than the non-COVID-19 associated GBS. Now, there's a large study that is very credible, and it is very well done. That's considered to be a source of evidence for this relation and association between COVID-19 and GBS. This came from the UK, and they studied. I'm sorry, I don't have a pointer. I just asked the IT guy. He said we don't provide pointers. What they did, they studied the incidence of GBS in the UK hospitals uh, uh, during the pandemic months, like from March, the first wave of the pandemic, the first peak. So we're talking about from March to January, from March to June, and that curve, the one that goes up, is the curve of the pandemic, and the columns underneath that represent the different years of the incidence of GBS. And the red column shows the incidence of GBS during the peak of the pandemic compared to the previous months before the pandemic and to the previous years. Really, there's not much of increase in the incidence of the GBS. If anything, there was slight decrease in the incidence of GBS during the pandemic. This is another curve that shows clearly, if you see the red line, a decline in the incidence of GBS during the first few months of the pandemic in the UK hospitals. And also, when they compared different regions in the UK and they compared the incidence of the GBS with the incidence of COVID-19, there was no correlation. The areas in the UK where the GBS was prevalent were different from the areas where the COVID-19 was prevalent, which again supports the lack of association between COVID-19 and GBS. Now, this study does not answer the specific question whether COVID-19 has increased the incidence of GBS. It just tells us whether the incidence of GBS during the pandemic has increased or decreased. So, was it possible to have a small increase, a small spike of the COVID-19 related GBS that was overshadowed by the overall decline of the incidence of the GBS due to other factors, such as social distancing, masking, isolation, etc.? We don't know. But if there was such an increase, it must be very, very low. And it would not justify it would not bring any important clinical implications. So far, there's no association between GBS and COVID-19. And the question that comes, people with immune-mediated neuropathies other than GBS, or CIDP, for example, or vasculitic neuropathy, multifocal motor neuropathy, are these people, they have increased risk of contracting SARS-CoV-2 infection? To date, there is no scientific evidence that immune-mediated neuropathy itself increases the risk of COVID-19 infection, or there's any association between immune-mediated neuropathy and the COVID-19 infection. Therefore, the guidelines at the time being is to continue the same treatment, including the IVIG, but try to seek some outpatient settings to avoid inpatient infection risk. And there's no evidence that IVIG is protective against COVID-19 either. Now, that is about neuropathies, but how about myasthenia gravis? Myasthenia gravis and COVID-19 infection is also seeking some answers that we don't have. There are a few case reports of new onset myasthenia that probably is an underlying myasthenia that was unmasked or exacerbated by COVID-19 rather than caused by it. Some medications that used to treat COVID-19, such as azithromycin and hydroxychloroquine, may increase the risk of exacerbation or may trigger exacerbation. Now, there's an international registry of COVID-19 and myasthenia gravis. Partial data was published, and it showed that 40% of MG patients experienced worsening of myasthenia that required rescue therapy, and 24% of patients died. So it seems that, according to this partial info, that the risk complications from COVID-19 is higher in patients with myasthenia gravis. Now, there are several studies trying to study the predictive factors for severe course of COVID-19 infection in patients with myasthenia. And one of the studies have shown that, for example, the graph to the left shows a correlation between vital capacity and the probability of severe COVID-19 infection, and shows that the lower the vital capacity, the more the likelihood of severe COVID-19 infection is. And the graph to the right shows the higher the dose of prednisone correlates with a higher incidence of or probability of severe disease. There are some other factors beside the steroid dose and the COVID-19 and the vital capacity, including the mycophenolate, including other factors like hypertension and diabetes, and other immunosuppressive agents. So sometimes it is a multifactorial issue that should be taken into consideration to stratify the risk of patients with myasthenia who get infection. But overall, it seems that patients with myasthenia, if they get COVID-19 infection, they are likely to get a severe infection. There are some ongoing studies are trying to look at the incidence of COVID-19 in myasthenia, and the factors that determine the outcome of COVID-19 infection in myasthenia, and the role of immunosuppressive therapy on the outcome. Again, the data so far is very conflicting. Also, as I mentioned earlier, that compared to general population so far, myasthenics seems to carry a high risk of hospitalization, ICU admission, and intubation. Our center is working with several other academic centers in a questionnaire or survey to look at some of these variables and regarding the outcome of COVID-19 in patients with myasthenia gravis. So currently, the guidelines for the management of myasthenia during COVID-19 are not very solid, but if patients with myasthenia are infected with COVID-19, we don't recommend any changes in the treatment. In very severe cases, treatment may need to be paused. Again, we encourage people to follow the precautions that everyone is asked to follow, like social distancing and vaccination and masking. There's no evidence that IVIG affects COVID-19 infection or vaccination. The plasma exchange may deplete, as you all know, that plasma exchange does deplete antibodies, and the COVID-19 risk should be calculated carefully in these patients. Now, there's something that we know, that beta cell depleting therapies like rituximab, they may increase the risk of complications. I'll show you some data later on. And therefore, it is recommended that they are delayed until after the peak of COVID-19 infection, or 2 weeks after the vaccination. Now, there are some other reports. If you survey the PubMed, you find reports of different things, and we just put them the way they are published, but that doesn't tell you whether they are really caused by COVID-19 infection. Like myalgia and fatigue are very common in patients with viral illnesses in general, including COVID-19. CK elevation is very common also. Now, in patients with chronic illness after COVID-19, fatigue and generalized weakness and myalgia are also very common. Also, we see patients with rhabdomyolysis. I've seen several cases of rhabdo in the hospital who had COVID-19 infection, but that should not be surprising because they are very well set for COVID-19, for rhabdomyolysis. You know, they get immobility, ischemia, drugs, electrolyte imbalance, in addition to the infection. All these are risk factors for rhabdomyolysis, and of course, rhabdo should be treated like any other rhabdo, regardless whether it's caused by the virus or not. Myositis, there are a few case reports of myositis and dermatomyositis, very convincing case reports of pathologically confirmed dermatomyositis that happened several weeks after COVID-19 infection and responded to steroids. Again, causation was difficult to determine, and there's no evidence of direct viral invasion to the muscle.
I had dropped feet after being in the hospital for a 6-month stay with COVID.
So you were in the hospital for 6 months from COVID, were intubated for 45 days,
Yes.
and then after you came out of it, you had bilateral foot drop, right?
Yes.
You were diabetic and you had also renal failure, you were on dialysis, right?
Yes.
So this patient he was in the unit for several weeks, and he had respiratory failure complicated by renal failure, sepsis, and no surprises. After he was discharged from the unit, he had severe weakness, bilateral foot drop, as you saw, no reflexes. EMG revealed severe axonal neuropathy. So this is a case of critical illness neuropathy in a patient with COVID-19 infection. As you know, that more than 2/3 of patients who stay in the ICU for more than 3 weeks, they get some degree of critical illness neuropathy or myopathy. And so it is common, regardless of the COVID-19 infection. Again, these people are immobile, they have sepsis, multi-organ failure, and systemic inflammatory response. And critical illness neuropathy is not unusual in these cases, and it should be treated the same way it is treated even without COVID-19 infection.
Caught COVID, went into the hospital for 70 days, 2 collapsed lungs, trach, feeding tube, woke up, no function of my right arm. Yeah, it's getting better.
Show me, what can you do there? Can you lift it?
I can lift here.
You could not do that before, right?
Before, no.
Okay. Can you make a muscle, biceps like this?
That's better.
You can't, so he has no biceps.
Yeah.
Push me. He has a good triceps.
Yeah.
Okay. Can you extend your wrist like this? You can't.
No.
Now squeeze my hand. He has very good hand grip. That's C8. Can you spread your fingers? He can spread his fingers. That's C8. His deltoid is fine. Push against me. Very strong deltoid and very strong supraspinatus. Weak pectoralis. So that's C7 and C6. Sensation here is different than here?
Yes.
Okay. He has a good biceps and brisk triceps reflex. You know, this is a case of brachial plexopathy after COVID-19 infection. I mean, about 12% of patients who were prone during COVID-19 related admission to the ICU. As you all know, that proning is a technique that's used to reduce the impact of pulmonary involvement in patients with COVID-19 infection, and especially patients with obesity, diabetes, hypertension, and unconsciousness. They are prone for stretching of the brachial plexus, and that can lead to plexopathy affecting different chords and different parts of the plexus. And usually it is multifocal. It is very hard to localize. You know it is in the plexus. If someone comes to you after, or you see someone after discharge from the ICU to the floor, you examine them, they cannot lift one or both arms in a very selective manner, biceps more than triceps, for example, or wrist extension more than flexion, with sensory symptoms, then this is most likely a brachial plexopathy. And don't feel bad if you cannot localize it, because usually multifocal. A study has shown that the upper trunk is affected in some cases, but the lateral cord is affected in more. And isolated ulnar neuropathy is also common in these cases, either because of the ulnar nerve or because of the medial cord involvement. So keep in mind brachial plexopathy in patient with COVID-19 because of the proning.
I had COVID in January of 21. It was a mild case. And then when I recovered and I went out to do a run, it was probably about 3 weeks after I got COVID. When I first started running, I could tell something was very different. I could barely make it about a half a block before I had to start walking. And I'm an avid runner, and I do Ironman events and things like that. And I just felt like a different person. It was just profoundly different.
Okay, and then what did the testing show?
So I had a fluoroscopy that showed that my left diaphragm is elevated and then not working. There was a paradoxal movement in it.
So this patient with COVID-19 infection had severe respiratory distress, but he had no pneumonia. And then when they did the sniff, they found paradoxical movement of the diaphragm. There are a few case reports of patients with phrenic palsy after COVID-19 infection. Again, we really don't know if there's a cause-effect relationship, but we know that patients with COVID-19, if they have shortness of breath and the lungs are clear and one side of the diaphragm is elevated, make sure to consider phrenic palsy. Now, what is the pathogenesis? What happens in patients with neuromuscular diseases when they get COVID-19 infection? I know people think that the pathology may relate to direct invasion of the virus to the neuromuscular system or immune-mediated injury. So far, no virus has been isolated from the spinal fluid or from the muscle or nerve, but upregulation of the immune system is very well found in the tissue in a study that was done at Harvard by Amato and his group. So far, no molecular mimicry was found between the viral genome or the proteinome and the peripheral nervous system. So they compared all the sequences of the DNA and the protein of the virus to the human DNA library, and they found no molecular mimicry, like you see with the Camelobacter jejuni in patients with GBS, for example. They did not find any antibodies like GM1 antibodies like you see in patients with CIDP or multifocal motor neuropathy. So far, there are no specific antibodies, and there are no DNA particles or protein particles in the tissue. So this is the study that I referred to. About 31 patients who died from COVID-19, they harvested the femoral nerve and the iliopsoas muscle, and they stained them with different stains, and they found there's a lot of endomesial and endoneural mononuclear inflammatory cells with invasion of non-necrotic muscle fibers and perivascular infiltration and cuffing. But there was no indication of viral DNA in the muscle or nerve. So it seems that most of the complications were due to upregulation of the immune system. Now we're going to talk a little bit about the COVID-19 vaccination. As you know, the multiple vaccinations were developed within a short period of time, and so far there are about 4 billion people nationwide are fully vaccinated. That's about half of the world population, and about 2/3 of the American population is so far fully vaccinated. So a huge number of patients have received the vaccination. Therefore, we have a lot of data to talk about the complication of the vaccinations. So far, 10 vaccinations have been approved, 18 are authorized for limited use, and 37 are in phase 3. So more vaccinations are coming. As you know, many of these vaccinations use RNA technology, which is a kind of a new, relatively new technique, and also some of them use a partial component of the virus, and some of them use attenuated virus.
On the 1st of February, I received COVID-19, my second round shot, and I'm a healthcare professional, and I felt warm and tingly on my arm, and the general things. And then that night, I had blood pressure elevated, and felt tingling going down my right arm. And after that, I felt it in both hands and a little tingling and numbness in my feet. When I woke up the next day, I almost all the way up to my ankles, I couldn't feel my feet, in both feet, and tingling, numbness, weakness, a little off balance from it. My speech has been kind of about probably 5 to 7 days after the shot. I noticed that when I speak, it sounds a little slurred, a little off. I never had that before. I always had very good speech.
This one up. Slight proximal weakness. Squeeze my hand hard. Hand strength is fine. Do like this. Push up real hard. Some proximal weakness. Her feet are normal. Your reflexes are absent or depressed. Do you feel any vibration here?
No.
So that is a big question. Does COVID-19 vaccine increase the risk of GBS? We just mentioned that there's no indication that COVID-19 infection increases the risk of GBS. Not the vaccine, the disease itself does not seem to increase the risk. But there are some case reports of patients with GBS that occurred within 2 to 3 weeks of COVID-19 vaccination. Like this lady you just saw, the nerve connection studies and the CSF exam, the clinical picture were very typical for GBS. Now, it is important to have an answer to this question because misattribution of events to the vaccination would harm the vaccination program and increase the mortality and suffering. So let us talk about this. The annual incidence of GBS is 1.7 per 100,000. So far, 4 billion people are vaccinated. That means by chance only, you are going to have 68,000 cases of GBS occur after the vaccine, and about 13,000 of them within 10 weeks of the vaccine, just by chance only. Translating that to the American numbers, the 2/3 of Americans are vaccinated. So by chance only, there's 340 cases of GBS may occur after the vaccination a year. That means 65 cases of GBS may occur by chance only within 10 weeks of COVID-19 vaccine. So if you see a paper that describes 60 cases of GBS, still that could be within the chance occurrence. You need to have more proof that the vaccination causes GBS. Basically, so far, the clinical trials on the RNA, messenger RNA, did not show any GBS in tens of thousands of patients. There was one case with the Johnson & Johnson, and the FDA put that in the issued an alert that there might be an increased incidence of GBS with Johnson & Johnson, and there is no increase again with the other vaccinations. So far, there are 7 billion doses are administered, and there's no indication that there's increase in the GBS risk. So these rare cases that are reported in association, probably they represent a chance occurrence rather than causation. So far, the history of GBS or Bell's palsy is not a contraindication, and the benefit outweigh the risk of the vaccination. And if you remember, when the swine vaccine GBS happened in the 70s, many, of course, in the beginning, doctors overlooked these cases, but later on, they found cluster of cases and they compared them to the general population. And the case control study very clearly showed that there was a much 10%, 10 times increase in the risk of GBS within a few weeks of the swine flu vaccine. Now, subsequently, when the vaccine is switched from swine to human and to partial DNA, then the future very extensive studies have not shown that the regular flu vaccine that you get every year increases the risk of GBS, but increases that by 1 million case a year. And therefore, of course, no one would like to be that one. Therefore, we have to stratify that and tell people that if you are very healthy, you don't need to have the flu shot. But if you have some other risk factors or you work in the hospital, then you need to take that small risk. So 1 per million, which is 10 times less than the risk of GBS after the swine flu. So people always ask, I had GBS before, can I take the flu shot? Can I take COVID-19 shot? Yes. I mean, there's no indication if you had a GBS before, you cannot take the vaccine. If you had GBS before, 2 weeks after the flu shot, then one has to discuss the risk properly. So far with COVID-19, we don't have that. Still, I see patients tell me that he got sick and got neuropathy or exacerbation of neuropathy within 2 weeks of the COVID-19 first or second shot. Can he or she get the booster or not? I mean, we don't have enough data to answer this question, but so far the COVID-19 vaccine, it seems that has more protective value than this very, very, very minimal risk of getting GBS. Of course, also CIDP can be exacerbated by any viral infection, including COVID-19, but most of the studies are very small and very limited, and one cannot draw very solid conclusion. The guidelines regarding vaccinations in patients with inflammatory neuropathy, again, the data are very weak and still wait for more confirmation by larger studies. One study has shown that 3.5% of GBS patients and 8% of CIDP patients reported worsening of neurological symptoms after immunization. I mean, you all know that any infection can exacerbate someone with a chronic disease like COPD or CIDP or GBS or myasthenia gravis. And so COVID-19 is not an exception. A viral illness that challenges the immune system, and it may trigger an immune reaction, or it may exacerbate an underlying immunological disorder. So currently, there is no data available on the safety and efficacy of the vaccine in patients with autoimmune diseases. Now, rituximab, this study shows that in patients with who take rituximab have failure of development of antibodies to vaccination. This is from patients with rheumatoid arthritis. And these are three strains of the flu vaccine. Say, look at the top one, for example. The black part of the column represent pre-existing antibodies, and the white one represent development of antibodies after flu vaccine. And the first one is HC, healthy control, and the second one is methotrexate, and the third one is rituximab. If you see that the patients who take rituximab did not develop a sufficient antibody response, and you see the white box is very small, which makes sense. You know, rituximab is a selective CD20 suppressor, and CD20 cells are important for the formation of antibodies, and therefore it is recommended that patients who take rituximab should delay that until a few weeks after the vaccine or after the pandemic.
So the day after I got my second dose of the Pfizer vaccine, I woke up and I had just what at first I thought was the normal vaccine symptoms like fever, body aches. But as soon as I stood up out of bed, I realized something was wrong. I felt really, really lightheaded, dizzy, like I was going to pass out. And so I put a pulse ox on my finger and my heart rate was 170.
So what do you feel when you stand up?
I feel just generally not good, just like weak, dizzy. I can feel my heart racing, and sometimes it's palpitations, so sometimes it will be like not a consistent heartbeat, it'll like flutter pretty much every single day.
So what would you do to avoid fainting?
Sit down.
You sit down. Pulse was about 74 beats per minute, and here she was tilted up. Immediately after she was tilted up, the pulse went to 133. Continued to be high, and then here where she was tilted down, it went down from 116 to 71, with no significant change in the blood pressure. So this is a case of POTS. There are several case reports of dysautonomia after COVID-19 infection. And this lady developed some orthostatic intolerance and fatigue. And as you saw, the autonomic reflexes testing clearly revealed postural tachycardia. So this lady had POTS after COVID-19 infection. Again, we don't know if this is a causation or just association, but I have seen many cases of orthostatic intolerance and POTS after COVID-19 infection. Also have seen many of these cases after other viral infections or after no infections. So we are waiting for the population-based studies and case control studies to tell us more about the incidence of dysautonomia in patients with COVID-19 infection and vaccination. I don't know if Dr. Vernino will mention that in his talk later today.
Random twitching throughout my body. My right finger is not double clicking a mouse.
Okay. And when did you start having those?
February 10th.
How long after you got the COVID vaccine?
Hours.
And they started in the site of the vaccine?
Correct. It started
Here?
in the area.
And then spread to the entire body. Any loss of muscle mass or weakness with it?
Other than the finger, I'm not aware of anything else.
I'm sure many of you face these challenging cases. When someone comes to you and tell you that right after the shot, I get tingling and twitching in the injection site and then spread to the entire body. On the one hand, pathophysiologically, this doesn't make sense. On the other hand, the patient seems to be very, very authentic, very legitimate. So to reconcile this, we have to really consider many things. Let me show you this video.
Muscular issues following my COVID Pfizer vaccine. Lost a lot of muscle bulk. Started noticing twitches in my arms and in my legs. I also noticed just inability to continue exercise, exercise intolerance, and extreme fatigue. And all of this was following my COVID vaccine inoculation from Pfizer.
How long after the vaccine the symptoms started?
A week and a half.
And did you lose muscle mass?
Yeah, September to now, which is January, I probably lost over 30 to 40 pounds of rock solid muscle here.
So are you still doing the same exercises you did before, or you are unable to lift as heavy weight?
Same exercises and nothing, no result.
You don't build any more muscles?
I don't build anything.
Okay. And did you say you had twitching also?
Twitching, it'll happen in the arms, it'll happen in the legs, calves, it'll happen chest, all over. With exercise, probably I would say 30 1300 to 1400.
Push up. Normal strength. Do like this. Push up. Normal strength.
So this patient was very athletic. And after the vaccine, he could not build any more muscles despite exercises. And he had some muscle twitching, lost muscle mass, and CPK was around 1300. As you know, that CK elevation is not uncommon in general population, especially African American athletic men. Up to 800 can be considered as normal. So many people are referred for biopsies for people with 500 CK. If they are normal AMG, normal strength, we don't do biopsy on them. So there are people who present with all these things. Of course, it may take us several years before really we get to the bottom of this. But at the time being, we need to also pay attention to the nocebo effect. This study is done by one of my colleagues in Italy. We have a group of work. We're working on the placebo and nocebo effect. And Dr. Amanzio put together all the COVID vaccine studies involving hundreds of thousands of people. So to the right is the vaccinated group, and to the left is the placebo group. And of course, fatigue, headache, local pain, myalgia, of course, they are more common in the vaccinated group. But if you look at the placebo group, you find really in all these three vaccinations, the top one is the Pfizer, and then the Moderna, and then the Johnson & Johnson, you see a significant number of these patients had fatigue, headache, local pain, myalgia, muscle pain. So it seems that adverse events associated with COVID-19 vaccine part of this may be related to the nocebo effect. Nocebo is when you have negative expectations, you are more likely to have side effects. So this is a very well established fact in the science of placebology. Positive expectations increase the incidence of a positive outcome, and negative expectations increase the incidence of negative outcome. And there are some correlations with certain chemicals in the brain that increase or decrease during these events. Like recently, we concluded a study that showed that people with nocebo effect had a high cortisol level that correlates with the magnitude of the nocebo effect. Not only that, that even patients with high nocebo effect, that they responded with a very high score in the to the nocebo challenge. The following their life when they were in utero, their mothers were pregnant with them. We found that the intrauterine cortisol level correlates with the nocebo effect during adulthood. It's a very interesting field. We're trying to decipher the different chemicals that are involved in the placebo and nocebo effect. Now, this is I know the words are barely readable, but I wanted to let you know that there are now clinics, centers in the country called post-COVID-19 complications, because many people are finding themselves to be unable to go back to work after COVID-19 infection or vaccination. Many of these patients continue to have very severe exhaustion and fatigue, myalgia, palpitation, headache, and so forth. Of course, we don't know about the exact relationship with the COVID-19 infection, but it is not very unusual to have a post-viral depression. If you remember, in the medical textbooks, they talk about post-flu depression syndrome. When people recover from the illness of the flu, they are usually depressed for a few days, and some of them, they continue to have chronic fatigue. And one of the theories of the chronic fatigue syndrome is people were exposed to some viruses, and that may have triggered the immune system to basically change the chemistry and cause chronic fatigue or fibromyalgia. So of course, the post COVID-19 syndrome affects different systems. Fatigue is the most common, and headache is common, but it can also cause a lot of other manifestations that affect different systems, including the heart, the GI, the joints, etc. So more studies are needed really to define this syndrome full dimensions. So in summary, no evidence that COVID-19 causes GBS or CIDP. There's no evidence that neuromuscular disorders are prone to COVID-19 infection. No evidence that COVID-19 virus invades the peripheral nervous system. No changes in the treatment regimen is advised in patients with neuromuscular diseases. And it seems that more severe COVID-19 infections noted in patients with neuromuscular diseases. Vaccination is recommended for patients with neuromuscular diseases that are considered to be risky, and rituximab may increase the risk of severe COVID-19 infection and reduced vaccine immunoreactivity, and therefore we recommend that rituximab is delayed for 2 weeks after the vaccine. Still, more studies are on the way to answer some of these questions. That concludes my presentation. I wanted to thank my friend David Paydarfer. I did not thank him. I think I was disturbed in the beginning because of the echo that I had. Dr. Paydarfer has added to the quality of neurological medicine in Texas very much. I think I remember the day when Dr. Fox and I visited him, and I think Texas is very lucky to have a scientist in his caliber. And thank you very much, David, for your kind words.
Well, thank you, Dr. Shaibani, for that really awesome overview of a very active area of research. It's really remarkable that so much knowledge has been gained so fast. It mirrors the remarkable speed at which the COVID vaccine itself was developed, and the work that you've summarized really brilliantly for clinicians. I really love your way of presenting the topic with cases that you present and then dive in. So I really appreciate that technique. We do have a virtual question that I'll start off with, and then we will invite folks to come to the mics live to ask Dr. Shaibani for his opinion. The virtual question is really about antibody levels after vaccination, and some of the topics that you covered with the vaccine. Is there any relationship with the COVID antibody is there any utility of the antibodies in trying to sort out these vaccine-related questions?
Yeah, I'm not an infectious disease specialist, so I don't have extensive knowledge about the antibody studies. As far as the neuromuscular disorders are concerned, I haven't seen any studies to correlate the level of antibodies after the vaccine with the development or recovery from neuromuscular disorders. Most people do antibodies after the vaccination to see if they have developed enough immune response, or maybe they need to have to repeat the vaccine or to have an earlier booster dose. Even that technique is not validated, and scientifically, people in the clinics, they don't ask for antibodies to give you the booster dose. In general, the antibodies in Pfizer study have shown that the antibodies decline after 6 months, and therefore a booster dose was recommended and is being given if you had the second dose 6 months earlier.
Thank you, Dr. Shaibani. So again, the live mics are open for questions. There is another virtual question that I'll go ahead and pose as we wait for others to come to the podium. Given the fact that COVID virus affects small blood vessels, is it possible or probable that the vasa nivorum is affected in severe cases? Is there any pathological or clinical evidence that is a mechanism?
Yeah, the study that I have shown from Boston, Tony Amato and his group analyzed 31 samples from the iliopsoas and femoral nerve from patients who died from COVID-19. They reacted the tissue to different antibodies and they stained the blood vessels, and they reacted the blood vessels and the nerves and the muscles against different viral particle antibodies. And they did not really find any indication that there was an invasion of the vasa nervorum or of the nerve tissue or muscle tissue. They found a lot of perivascular cuffing and infiltration and invasion of the muscle fibers with mononuclear cells, CD4, CD8, and a lot of macrophages, but they did not find any traces of the viral particles in the vasa nervorum or in the nerves or muscles.
And a related, just a related topic, clinically, when we consult on these cases, do you see, painful mononeuropathy multiplex with infarction patterns that you would see with vasculitides? Have you seen cases of that?
I haven't seen cases with vasculitis. I've seen some cases with non-diabetic lumbosacral radiculoplexus neuropathy, which is probably a coincidence because we see these cases all the time. It's 1% of diabetic neuropathies belong to this category, and this is due to microvasculitis. But we haven't seen cases that followed COVID-19 infection. I'm not aware of any reported cases of vasculitic neuropathy after COVID-19 infection.
Thank you very much. Well, this has been a really illuminating talk, and really thanks again. Round applause for Dr. Shaibani.
Thank you very much. My pleasure.